We're going to move on to the next topic, which is so very important to this whole question of disproportionality, and that's the issue of research. We've heard so much that Black men do not take part in research. So what we want to do is examine how research is going to play an important role in this. And for this, I'm going to introduce Dr. Aisha Lofters, a family physician and a scientist at Women's College Hospital. So don't let Women's College throw you off. She's also an associate professor at the University of Toronto in the Department of Family and Community Medicine, a scientist at the Institute for Clinical Evaluations Sciences. I should point out that back in 2022, Dr. Lofters, Anthony Henry, and I partnered on a published paper on the incidence of prostate cancer among immigrant men in Ontario. And that paper was published in the Canadian Medical Association Open Journal. And sure, she's going to talk about it. She's a great friend of the foundation. Aisha?
Thank you, everybody. Can you hear me? Okay. Yeah. Okay. We can jump right into the next slide. I'm going to be co-presenting with Dr. Jackie Bender, who you see sitting over there, my colleague and friend. But I'll start off, and then I'll pass the baton to Jackie for the next session. And what we want to talk really is about changing the landscape for Black men and just why it's important to why research is important and why participation in research is important. Next slide. So this has come up several times already, and Dr. Fleshner mentioned this. When we look at data from the US, we know that the death rate from prostate cancer in the US for Black men is 2.5 times to 3 times higher for Black men versus white men. We know that Black men are more likely to be diagnosed at later stages with prostate cancer, more aggressive forms, and more likely to be diagnosed with distant metastases at the time of diagnosis for prostate cancer. Next slide. But that's American data. And we use American data a lot in the world of prostate cancer. But as Dr. Fleshner just said, and as we're all aware, Canada's a very different country. We, in the US, most African Americans are of West African ancestry, and they've been Canada, which is another whole other topic. But we do have immigration data. And we took a look at the incidence of prostate cancer over several years. So if you look at this graph, going from left to right, you're going from 2008 to 2016. And all these funny colored lines are basically different regions of origins for immigrants. And you see that there's a bluish line at the very top. That's immigrants coming from West Africa. With this group looked at mortality inequalities of Black adults in Canada. So this was finally a study looking at actual race data, looking at actually a variety of illnesses and diseases across the spectrum. If you could hit the next button. And what this group found is that Black Canada, and that's because of a lack of research. So those two pieces I just showed you, they come from research. That's how we get these findings, but there's very little research that's been done in the Black community in general in Canada regarding health and regarding prostate cancer. Next slide. So let's back up a little bit, because whenever I say that I'm a researcher, all people think I'm cutting open mice or I'm looking under a microscope at different things. But research really just means it's a creative and systematic work to increase knowledge on a topic. So anytime that you're trying to investigate a question, you're wondering things, you're trying things out, you're looking at data, all of that qualifies as research. So different examples is looking at existing data. That's what we did with the work with Ken and Anthony. We looked at OHIP data, interviewing patients. So Dr. Fleshner mentioned that. We'll talk a little bit more about that. Filling out a survey, or you're filling out a questionnaire, that's you participating in research. The traditional, laboratory research that you all might think of, looking under a microscope and pipetting and those things that we did back in high school. Testing drugs against one another, so drug A versus drug B, or different doses of drugs or different formulations of drugs, whether it's given every 6 months versus monthly, et cetera. And then looking at new innovations, looking at new ways of doing things and getting feedback. All of those are actually research. Next slide. So what are the benefits of research participation? This is an animation, so you can just kind of hit through. So these are all things that actually are concrete benefits of participating in research. So first of all, knowing which differences exist for Black men, where they exist. So we talked about what part of the world that people are coming from. What are the reasons behind those differences? Is it diet? Is it environmental exposures? Is it pollutants in the air? Is it lifestyle factors? There's also speculation, I know, in the Caribbean about if there are particular foods that could be causing higher rates of prostate cancer. To know that requires doing research. Thinking about treatments and innovations that at least include Black men in the research for it. So new medications, new treatments. Dr. Fleshner just talked about this new gene that could have a medication associated with it. You need to participate in research for us to know about those genes and to find the medications that can benefit you. Early access to cutting edge treatment. So sometimes my father didn't have prostate cancer, he had myeloma, but he was actually able to get access to a very expensive medication through a clinical trial that otherwise would just not have been possible, and got 3 more years of life because of it. So you can get early access to these cutting edge treatments that can otherwise just be inaccessible. A capacity building in the community. So if we work with community partners on research, then now people in the community have learned how to participate in research themselves and can go on to become researchers. And then most importantly, it's a chance to actually have a direct impact on policy, on healthcare guidelines, and on where resources are going. When the government and healthcare makers and policymakers are trying to determine what do we want to support, where do we want to put our resources, they will often turn to research and turn to evidence to be able to inform that. So we need to be at the table when those decisions are being made. And it's also a chance to speak for yourself, not have others speak for you. The research is going to be happening anyway. So it's a chance to say, if it's happening anyway, let us be involved in it so things are not moving forward without us. Now, I'm making it all sound very rosy, but again, as has been mentioned before, research has not always served us well. And, the Tuskegee experiments were brought up. That was way in the past, but I think we also have to remember that there's injustice happening every day, and that continues to build that distrust that many people have in research. So this is actually, this was shared by a colleague of ours. It was work done from the US, just looking at what might influence a cancer patient's decision to not participate in trials. And as you can see here, people talk specifically about Black patients. They talked about trusting their particular cancer medical teams, but they still had a lingering distrust in clinical research. And 20% of Black patients, compared to 0% of non-Black patients, reported that they agreed that research harmed minority patients. So that's a really striking difference, 20% versus 0%. And the Black participants were 10 times more likely than non-Black patients to say that they felt that they and their community had nothing to gain from participating in clinical research. So again, this very large difference that we see, and it's a US study, but it happened very, very recently. So we know that there is this distrust in the community. And as I said, a lot of it's not irrational. It comes from what's happened historically, and is quite frankly, very understandable. So I do want to emphasize to you that if you participate in research, that research, Dr. Fleshner mentioned having to go through an ethics board. All research has to go through an ethics board, and it's reviewed from that perspective, not from benefiting the researcher, but reviewed from the perspective of preserving the rights of the participants. And if you're going to participate in research, you have the right to ethical and appropriate research. So what that means is that you should have the opportunity to learn and understand all the details about the study. So if somebody explains a study to you and you're confused, you have the right to ask more questions, to learn more, to take those papers home, to read about the study, to ask more questions so that you fully understand what it is that you're signing up for. Having all your questions answered. So there's no question that you should be withholding if you're participating in research. That's your right. Changing your mind. So any study at any time, you can say, you know what, I don't want to do this anymore for whatever reason. And again, that is your right. And then to also have someone that you can contact to ask questions, both as part of the study team and also the research ethics board team. Next. And then, of course, too, if you participate in a study, it should not be an extractive process where you give and then you never hear anything about it again. You have the right to know, what did we learn about that drug at the end of the day? What did we learn from those interviews? What did we learn from those surveys? And to be able to say, oh, this is how I have contributed to science and to the new evidence that's out there. So I'm going to give you one example of ongoing research that we're doing, and then Jackie's going to give you another example from work that she's done. This is work that's happening right now, so you have a chance to participate in this work if you so choose. And this work, I really want to say, came out of that work that we did with Ken and Anthony, looking at that Ontario data and then trying to think, you know, what's next? We see these higher numbers. We heard stories from Ken and Anthony and thinking about what can we do next to address what's happening in the prostate cancer environment in Canada. So right now we're working to understand what are the barriers that black men with prostate cancer and their caregivers face when they're going through their prostate cancer journey. Are they getting the same quality care? Are physicians understanding their experience? Is there awareness in the community, et cetera? And we want to not just do that just to write it up in a journal, but also to actually co-create some materials for providers and for patients. Dr. Fleshner is doing similar work. So we were whispering that we need to chat with him so that we are synergizing and collaborating, not doing things in silos. And then also we want to evaluate and understand, are these tools actually working? And all these are very classic elements of research. Next slide. It is also a very broad team. So there's Jackie and myself, Dr. Paul Wonka, who's based at McGill. We have two research coordinators working with us, partners here in Ontario, in Nova Scotia, in Alberta, and Quebec, because we want to ensure that we have a broad range of Black men's experiences in different communities. We're working with specialists. And I do want to highlight that we have a lot of support from the Canadian Cancer Society. Some of you may be familiar that they're really interested right now in prostate cancer and supporting Black men specifically with prostate cancer. Next slide. So right now what we're doing is we're conducting interviews with men as well as their caregivers. So we also want to talk to wives, to partners, to adult children to understand that perspective as well. And then we're going to create our tools that we want to use. We want to make tools for Black men and their families and the public. We've already learned the importance of understanding your family history, lots of stigma around prostate cancer. But also we want to make tools for clinicians, because we've also learned that clinicians have a lot of work to do as far as, making stereotypical comments, not really understanding culture. So there's work to do on both sides. Next slide. So far, we've conducted over 20 interviews. Not surprisingly, most have been in Ontario, but we do have some in Alberta, Quebec, and Nova Scotia. Interestingly, you saw on that slide that the highest incidence for prostate cancer was in West African men, but most of our participants have been from the Caribbean. We're having a much harder time recruiting men of West African background, so that could be a point of discussion. What we're finding so far, as I said, is that there's really limited knowledge about family history. There have definitely been experiences of physicians being biased, saying, offensive and problematic things, and negative way. People have competing life priorities. This came up in the presentation about masculinity. So, men having other things that they want to focus on, mistrust of healthcare, misinformation. So a lot of false information about prostate cancer. And then really importantly, the need to break the silence. And I've heard that come up in multiple presentations, is that women, there's so much movement around breast cancer because women talk very, very openly about it, but we're not seeing the same thing happening in prostate cancer, despite it being of a similar prevalence. So there's really the need to break that silence. These are some quotes that we've actually found from interviews that we did. So maybe I'll just give you a second to read through. So this first quote really just highlighting again this point about family history. Dr. Fleshner talked about genetic testing, but before genetic testing comes knowing your family history, right? A lot of people will say, my uncle had a cancer or he died, but no one knows why he died. No one talked about it. And then you can't qualify for genetic testing. The second one touching really about the idea of a digital rectal exam. And again, when we think about masculinity, especially coming from cultures with previous histories of slavery where men were emasculated, and there's such a strong push to fight against that, that a lot of men are very resistant to the idea of having a prostate exam. Questioning your doctor. So not just saying, okay, yes, and nodding. When your doctor is saying things using big words, you have no idea what's going on, but recognizing it's okay to say, wait, stop, I have questions for you. That's what that first quote is really touching at. It may sound like a dumb question, but help me understand, I don't get it. And the last one has come up quite a few times in these interviews that we've been doing, the idea of faith and kind of creating a false dichotomy between faith and medicine, and this idea that we can pray it away, and if it's God's will, and that's something that I think we've got to really look at within our Black communities. We've also been asking people, what should we do? Like, how should we deal with this? And this is what the interviewees have told us. So starting conversations, so things like today where we're having conversations, but bringing that more broadly into Black communities. Black prostate cancer support groups came up. So thinking of the Walnut Foundation, taking a for Black people by Black people approach. So again, coming from the community itself as opposed to being imposed on the community. People have talked about health coaches and they talked about peer navigation. So we'll hear a little bit more about that in Jackie's talk. So
address and I'll pass it on to the team. It's so very important that we get more people taking part in that research. Okay. And I believe you pay $50. Co-lead of Equity, Diversity, and Inclusion Cancer Rehabilitation and the Survivorship Program in the Department of Supportive Care at Princess Margaret Cancer Center. She's also an assistant professor at the Dalai Lama School of Public Health and Institute of Health Policy Management and Evaluation at the University of Toronto. She's no stranger to the Walnut Foundation. In fact, many years ago, Dr. Winston Isaac, who created the Walnut Foundation, worked with her in creating the peer some person coming.
Thanks so much, Ken. Thanks, everybody. I might be one of the smaller. I'm certainly not as tall as Chris Bennett. So as I look at this stool, I'm thinking, oh my goodness, are my feet going to touch the floor over there? All right. So I'm going to bring this down. And I've also passed 40. I'm more than just past 40. And so now I need 2 glasses. So, well, I don't think I need these. I have one eye that's nearsighted and the other eye that's farsighted. So my eyes are good. I can see the slides. So thank you so much. I really appreciate this opportunity. Dr. Lofters and I were really excited to come here today to talk to you about the work we've been doing with the Walnut Foundation. Well, for me, over 10 years now. So Dr. Lofters gave you an introduction to the importance of research within this community. And I'm going to tell you a little bit about a project that addresses one of the recommended solutions from this research. So Aisha and I have been conducting interviews with Black men with prostate cancer and their family members across Canada. And one of the things that we're learning about from them is that they would really like to connect to someone else, another guy, or if it's a family member, another caregiver who's gone through the prostate cancer experience, to really hear what it's like and to learn what they can do to sort of cope with some symptoms and side effects and have a sort of healthy recovery. So I'm going to talk to you about a peer navigation program that I designed and developed starting over 10 years ago. Actually, it's nice to be here in the Movember studios because the funding to initiate that work came from Movember. So we got a grant from Prostate Cancer Canada at that time that was funded from Movember that led to this series of multi-year work to develop this peer navigation program. So really nice to be back here in the office to say, hey, this is what has come out of this project. So I'm going to be talking to you about some work that demonstrates that this peer navigation program can help to overcome barriers to care and support for men with prostate cancer and Black men with prostate cancer specifically. So I'll give you a little bit of a background. You've had a bit of a background on the incidence of prostate cancer from the other speakers, but I'll just give a little bit of a background to get us started. So while prostate cancer is a highly curable cancer, really the 5-year survival rate for prostate cancer is at 93, 95%. It's a very curable cancer. That happens when you get in early, right? When you have an opportunity to get a sense of what may be happening in your body and get some screening, active surveillance, or treatment early on. However, even though all the treatments are highly effective in curing cancer, in curing prostate cancer, there are some significant side effects of prostate cancer treatment that really can impair quality of life. And we've been hearing about those today. We've been hearing about the sexual dysfunction and some of the erectile dysfunction and the impact on sexual relationships and relationships in general. We've been hearing a bit about the urinary incontinence and any bowel changes that can happen following treatment. And of course, all of this is associated with some distress, some considerable distress. And oftentimes, these effects of treatment aren't well addressed in general. Because there's not a lot of access to supportive care presented to patients, and patients are also not asking about it because they're not aware that it exists. I also want to sort of emphasize, though, that Black men face very unique challenges to high quality care for prostate cancer. We know, we've been hearing about this from many speakers, that Black men have a higher incidence of prostate cancer. We've seen that in the US. We've demonstrated that in Canada. If on average, white men, for example, would have a 1 in 8 chance of developing prostate cancer, Black men typically have about a 1 in 4 chance of developing prostate cancer. We also know that Black men report inadequate post-treatment care. They're telling us that they're not learning about these support programs, treatments, and services to deal with some of these treatments, the treatment side effects that we've been talking about. We also know that Black men are less likely to attend follow-up appointments. So when you have a diagnosis of prostate cancer, and if you're on active surveillance, we heard about a lot of the follow-up that Anthony was going through for active surveillance. Once you're treated for prostate cancer, you also have to go through follow-up to continue with those checkups, to monitor your health, and to monitor potentially some cancer recurrence. And so we know that Black men are less likely to follow up and attend follow-up appointments in some cases, and access psychosocial support services. But we have a good understanding of why that's happening, right? We've been hearing about the mistrust in the healthcare system. We've been hearing about the abuses that have been happening over the years, the historical abuses with respect to Black men being used to understand what's happening in our bodies and not being told the truth when they do participate in research. So we understand why there's this mistrust and lack of access to these support programs and services. We've learned that some of these barriers to post-treatment care amongst Black men with prostate cancer are stigma. We've heard a lot about that today. Dr. Shane Joseph gave us a fantastic presentation on the impact of stigma and our perceptions of masculinity, and how, if that doesn't include sort of a whole person approach, that may prevent some people from accessing support because of concerns about stigma associated with prostate cancer. Racism, there's widespread racism throughout Canada. We hear a lot about it from the US. There's widespread racism in Canada that we have to confront head on. And of course, there's a lack of awareness of men, and as well as healthcare professionals, and a lack of referrals to these support programs, and financial challenges. What we know are some of the facilitators to post-treatment care and improving that quality of life and getting those side effects treated are navigation. Navigation is a very effective intervention, as well as culturally tailored and relevant resources that resonate with the people that you're trying to care for, as well as self-motivation. So navigation, I just want to give you a brief history, was essentially proposed as a potential solution to improve access to care in the late 1990s, early 2000s by a physician by the name of Dr. Harold Freeman. He introduced it as a mechanism to increase access to care for Black women with breast cancer in Harlem, New York, recognized that there was a high rate of late diagnoses in this population, and felt that, well, if he collaborated with community and got people to screening and diagnosis earlier, we'd see some better outcomes. And that's exactly what's happened. So navigation is an intervention that helps improve access to treatment and services to improve health outcomes. Next slide, please. Stuck? And so there's many models of navigation. Navigation involves being paired with a navigator. A navigator could be a nurse. A navigator could be a social worker. A navigator could be a lay person without a clinical background from your community. A navigator can also be a former cancer patient. And what we're hearing from Black men with prostate cancer is they'd really like to connect with another guy, a Black man like them who has had prostate cancer, so that they can speak openly with that individual and say, hey, what's going on here? Is this not what I thought was going to happen? And so how do we move forward? How did you move forward? And what can we do together so that I can get the support and services we need? The advantages of what's called a peer navigator. So when you have a cancer survivor in the role of a navigator, that's called a peer navigator, is that they provide authentic empathy. So empathy is a critical aspect of care, and authentic empathy is getting empathy from someone who knows and understands what it's like. It's that having that sort of immediate shared understanding that they really get it. Providing another advantage of a peer navigator is that it helps to reduce disparities in access to care. So connecting with people from the same geography, from the same community, with the same language really does help improve access to services. It's huge. Axon survivors' desire to give back. We hear from many patients that they would love to get back and help other people through the cancer experience and help them get access to services that they may not have had access to themselves. We also know that it benefits the support provider. So the navigator gets something out of it too. The navigator benefits from an increased sense of self and self-esteem, and just the feeling of helping others is an incredibly helpful outcome that actually boosts your sense of wellness. Also increases visit capacity. So while we may want healthcare professionals doing all these navigation services, it's not possible. We have very little time with our healthcare professionals in our appointments with them. And we really need to find other ways, such as engaging cancer survivors who want to give back and help other people through the journey to help us access that care. And it certainly would be less costly hiring or engaging a volunteer or hiring a cancer survivor than a nurse or a physician in those roles. So knowing all of this, we developed what's called a True North Peer Navigation Program. And this was with funding from Movember and Prostate Cancer Canada. And so this is essentially a virtual navigation program that connects men with prostate cancer and or their family caregivers with a trained peer navigator who provides them support through the prostate cancer journey. What are the functions of a peer navigator? It's that classic navigation intervention. So this is more than a support group. Support groups are extremely important and very effective. What a navigator does is assesses on identifying what are your needs right now. It's very goal-oriented. What are the barriers to getting those needs met? Now let's work together and get you towards those goals and help you get the support that you need to get your needs met. Also, peer navigators provide that really essential practical, informational, emotional support that you may not be getting from other people. These patients and navigators have very intimate conversations about things that they don't talk to anyone else about. And that's a really important aspect of that navigating relationship. And then the navigators empower a proactive approach to health. And so what that means is they empower the individuals with knowledge and skills and confidence to ask questions in those clinical encounters, to ask for a second opinion, to find out where there are other supports and services, to say, hey, there are people like me in these support groups. I don't want to participate. I want to find an organization like the Walnut Foundation where I can really connect with members of my community and get the support that I need. Next slide, please. Central to, from my view, to any navigation program and any support program is partnership with community. And so we have been really fortunate to have partnered with the Walnut Foundation for over 10 years. Ken brought up Dr. Winston Isaac. So I met him long time ago and collaborated with him and Simon to create this peer navigation program for all men with prostate cancer, but really ensuring that from the very beginning, we were considering the needs of Black men with prostate cancer, knowing there's a higher incidence of prostate cancer in Black men, and knowing that Black men have unique needs that need to be addressed. So we have engaged 7 men from the Walnut Foundation, and they participated in the training program to be peer navigators, and they're available to be matched with men that are just getting diagnosed and wanting support through the prostate cancer journey. A week stretched over the course of 8 weeks. And it's very didactic as well as interactive. We have a lot of role plays and case scenarios, and we work together to develop communication skills and learn motivational interviewing to be effective in our role as navigators. We also built a digital app that allows us to connect patients with navigators, kind of like a dating app, actually. So a patient would sign up, answer a series of questions, and then the app baseload, access information and resources to send them. And then throughout this whole program, there's ongoing supervision and support. So first and foremost, we care about those navigators. We want to make sure the navigators are well supported and well taken care of in their role as navigators. So I'm just going to go through this quickly. That's perfect. The next one. So these are just some screenshots of the app. So there's the homepage. Screenshot 2 shows you that as you register on the app, you're asked some information about yourself, your age, your diagnosis, the treatments you've received. That information feeds an AI algorithm that then generates navigators that are similar to you based on those characteristics. And then you can browse the navigators and say, they can use to manage all their matches. And then there's a resource library with vetted resources about prostate cancer, which the patient can access and which the navigator can access. Next slide, please. So we've done a number of studies on this program, and most recently, I'm excited to share the results of a randomized clinical trial that we conducted on the use of this peer navigation program in men with prostate cancer in Ontario, British Columbia, and Nova Scotia. Next slide, please. And so who participated? So we recruited 184 people, and ultimately 172 people participated. They were randomized, like flipping a coin. They got a 50-50 chance of being assigned what's called the intervention group and being given access to peer navigation right away. So that meant they had access to the whole peer navigation program and the peer navigator right away, or they were randomized to what's called the control condition, where they had to wait 3 months until they got access to the navigator. And the reason why we did that is we needed a comparison group. A randomized controlled trial is regarded as one of the stronger study designs that allows us to determine the effects of an intervention. All these drugs and treatment approaches that we use are all tested using clinical trials. And so on average, the people who participated were about 67 years of age, and 81% who participated, so we recruited from Princess Margaret Cancer Centre, the Queen Elizabeth II in Halifax, Nova Scotia, and the BC Cancer Agency in Vancouver, 81% identified as white. Higher than I was wanting, to be quite frank. I was looking for a more diverse sample, particularly recruiting in the downtown Toronto. We know that 52% of individuals in downtown Toronto identify as racialized, but we're not seeing that population at Princess Margaret. Only 6%, 10 participants identified as Black. We designed this program to ensure that it can meet the needs of Black men and have engaged these fabulous navigators who identify as Black to ensure that we can provide this support that's needed for the post-treatment care journey of Black men with prostate cancer. But we know that there's some really very valid reasons why we're not reaching Black men, and Black men are not participating in some of these research. And Dr. Lofters has gone through a number of these reasons in detail in her presentation. We've heard about these reasons in other projects as well. There continues to be distrust and mistrust of the medical system and of health research in general, and it's understandable, right? Also, we hear that there's a feeling that, what am I really going to get out of this? How is this really going to benefit me? Is this program or treatment that you've designed, has it considered me from the very beginning? Has it been designed for white men, or has it been designed for people like me too, right? And so it's very understandable. But what we need to do is we really need to engage more members of the community in research so that we can develop treatments and care that's tailored to their needs and perspectives and their desired outcomes. Next slide, please. So I will say that the results of the study were very positive, pleased to say, and I think we've still got some Movember folks here. I don't think they know this yet either, that this randomized controlled trial that we run of the peer navigation program was shown to be highly successful. So it resulted in significant benefits for patients. Patients significantly improved in what's called their patient activation, and I'll tell you a little bit more about that, significantly increased their quality of life. It reduced their depression. It also reduced their supportive care needs. So they came in with many supportive care needs. The navigator helped them meet many of these needs. So at the end of the intervention, they had fewer supportive care needs. And the control group, there were no benefits whatsoever. So the intervention group that got the peer navigation program benefited. The control group did not benefit. And that really demonstrates these effects. So I'm highlighting patient activation because this is a really useful concept that we look for and oftentimes design services and interventions to target. Patient activation is that knowledge, skills, and confidence to actively engage in our health and access healthcare. There's different levels of patient activation. At the level 1 level, that's someone who would be disengaged and who's not sort of asking questions, may not have enough knowledge to take an active role in engaging in lifestyle behaviors. And then on the level 4, that's the active engaged patients who's asking questions, asking for second opinions, looking for support programs and services, engaging in lifestyle behaviors, really sort of taking good care of themselves. And we know that patient activation is highly associated with better health outcomes. lower blood glucose, lower blood pressure, as well as a number of other important chronic disease health outcomes. Next slide, please. So what we saw in this program, so this is a graph showing you on your left-hand side at the beginning of the graph is time 1 before the intervention started. And the red line is the intervention group. And we see that the red line improves significantly over time. Rather, it improves from time 1 to time 2 in patient activation, where the control group did not improve at all. And so that's another way of showing you that this intervention was effective. But let's look a little bit closer at patient activation. Next slide, please. We did do what's called analysis by race. So we did race stratified analysis. So we had 172 people participating, and the majority of those individuals were white. We had about 10 people identify as Asian. There is East Asian, South Asian mixed within that, and that should be disaggregated. Those are very different cultures. 10 identified as Black. And even within Black, we need to disaggregate further because the Black community is not a monolith. We know a lot about differences between Caribbean and African, and the immigration patterns to Canada. The Black communities come from 180 different countries. So we really need to disaggregate that as well. And then if we look at the white and the whole group, what we learn is that there is an improvement that we're seeing in terms of what the people who identify as Black experienced in the program, but that sample is too small for us to analyze that. So when you conduct research, you need a big enough sample in order to really see an effect. So we can see an effect in the white group. We can see an effect in the whole group, but we're not seeing we're not able to say, yes, this significantly improves the experience of Black men because we don't have enough people in that sample. So what do we need to do? We need to do more research, and we need to engage more Black men and their families in research. If you just can pop to that last slide. So the next steps are we will be conducting a workshop with Black men and their families to understand how to optimize peer navigation for Black men and their families. And that includes how do we get better at reaching Black men and their families? It's likely not just staying at the Princess Margaret Cancer Center and offering it there, right? It's also reaching out to communities where there's a higher proportion of Black identifying individuals. And so we're partnering with urologists in Mississauga, in Brampton, in Scarborough, in Ontario, as an example, as well as 2 other growing communities. So the 3 regions of Canada that have the largest proportions of Black identifying Canadians are, in fact, Ontario has the largest, but then Nova Scotia has the longest standing, and Alberta has the fastest growing. And we say different distributions of ethnicities across those different communities as well. We also have been hearing that we probably should offer both low and high tech options, that for those people that may not be as comfortable using apps or the internet, we should facilitate a way for them to connect with a navigator without using the app. And we've also learned that we probably should tailor the support given to really boost patient activation that aligns with the cultural preferences and experiences of Black men as well. And so what we're going to do is we are looking forward to doing what's called another randomized control trial of this peer navigation program, specifically in Black men across the country. So looking forward to coming back and talking to you when that project's over. But thank you so much for your time, and thank you so much to everyone for their role. This was a big team, and I appreciate the community partnership is essential. So thank you so much, Ken and Anthony. Couldn't do any of this without you, and the Walnut Foundation as a whole, as well as the rest of the team.
Thank you. So are there any questions for both Dr. Lofters or Dr. Bender? No. Are there any online questions? No. Or
If you have ideas, don't be quiet. Feel free to share with us. We don't pretend to know everything.
Anthony.
Any support, any assistance you all can provide. So appreciate it.
So, did you have a question?
Yeah.
Go ahead. She can't hear.
Just a question with regards to the outreach part. So when the outreach is happening, how is that happening? Like who's going into these communities and connecting with the Black community? Are there people that look like them, or some people, sometimes people they relate to people that look like them, or they feel more comfortable, and we've been hearing throughout with issues. Yes. So just curious about that, and are we looking at like these big geographical areas, or are we sometimes looking at a small community? And even though we're only two people out, but I mean, if it's an ongoing kind of some kind of like a mobile rotation.
Thank you. Some kind of a mobile rotation of where you're connecting into these really small pockets of communities. I'm going to use examples for the Jane Finch community, for example. Like there's so many different neighborhoods and pockets in that area. So I was just curious, how is the outreach happening and who is going out doing the outreach? And one more thing, who's sitting at these tables when the systems are being developed in regards to how we're going to outreach to the Black community?
Yeah, these are excellent questions. Thank you so much. For the clinical trial results that I showed you, that was across men with prostate cancer in general, that included Black men, but wasn't focused on Black men. We were recruiting in clinics, right? Not in community. So that means that research coordinators of different backgrounds and ethnicities, not necessarily Black identifying, right, would be going into clinics, working with urologists like Dr. Fleshner to say, hey, these people are eligible for the clinical trial. Could you speak to them? After you speak to them, can I speak to them? That's how it works, right? And then after their appointments, the research coordinator would go in to say, well, you are eligible to participate in this clinical trial. This is what it's involved. These are the potential opportunities. So that's how that intervention worked. Moving forward, recognizing that we're not reaching and recruiting a large enough sample of Black men, we've got to do it a bit differently. First of all, we can't just rely on Princess Margaret Cancer Centre. And even though we were recruiting in Halifax and Vancouver, there's not as large a population of Black identifying residents in Vancouver. There is a fair proportion in Halifax and Nova Scotia, but maybe not necessarily in Halifax, in the community surrounding the greater Halifax area. And in fact, in the study that we're also learning about these really important stories in these smaller communities. And I'm thinking specifically, actually, of some smaller communities in Nova Scotia, that if we didn't have a different outreach strategy. So for that strategy, for that qualitative project, we collaborated with 3 Black organizations across Canada and then worked with them to say, you tell us, right? What is the best way to reach out to different Black communities, to engage people, to start talking to us and telling us their story? That project, I think I'm the only non-Black identifying individual in that project. So people can talk to people who they resonate with and look like them. And that's really important. Clinicians like Dr. Lofters and Dr. Morrison that we heard earlier today, right? We need greater representation in medicine and in research. Mm-hmm.
If I could just add one thing too. So as Jackie said, with the study that we're working on, we were very purposeful about hiring research coordinators who were Black. And we also recognized, so for our interviews, there are really 3 people who are involved. So Dr. Wonka, who's part of the team, and then our 2 research coordinators. Dr. Wonka is a man, and then our 2 research coordinators are women, because we've found that sometimes the Black man does not want to talk to another Black man. talking about multiple communities and many, many different individuals who have their different preferences. So I think it's to take that, we traditionally in healthcare take this very one size fits all approach, and that's just not the way the world works.
There was a question online. Are there opportunities to participate in trials outside of Toronto and immediate areas, example, Eastern Ontario, Ottawa, etc.?
Yes, absolutely. There's opportunities to participate in the trials that I spoke of, but also opportunities to participate in many other trials. So I would say I'd encourage you to reach out and connect with either myself or Dr. Lofters, and we can provide you some more information about how to learn about trials that may be relevant to you.
And I know that there's work being done to build up a cancer clinical trials network for just that reason. So it's not just people at these specific, downtown large hospitals, but that people at hospitals across the country can participate in clinical trials. So there's work being done to build up a network around that and to increase diversity in terms of who is participating in clinical trials.
So this is a slightly different question. So the peer navigation platform is built for prostate cancer. Is there any potential to use that for other diseases like diabetes?
Yes, absolutely. You nicely walked me into talking about some other work. So while I haven't branched into diabetes, and it doesn't have to be me doing it, certainly I should say that because of the success of the peer navigation program for men with prostate cancer and their family caregivers, I've since expanded it to adolescents and young adults with cancer. So I'm offering it to adolescents and young adults. That means people who are diagnosed between ages 15 to 39 with cancer, with breast cancer, testicular cancer, sarcoma, and lymphoma currently. We've also expanded it out to individuals with head and neck cancers. So there's a range of different head and neck cancers. But the concept of peer navigation isn't unique and only important for cancer. Really, navigation is a really effective intervention for any health issue to help people navigate the healthcare system. Right. And we know more about it in cancer because of this formative work that Dr. Harold Freeman did for 25 years ago, focusing on the needs of Black African American women in Harlem, New York. So because that was the original sort of lay peer navigation program, we know more about this in cancer, but it's an intervention that could work for any health issue to navigate the health and social system, the health and health care and social care systems.
The one thing I wanted to point out is Dr. Fleshner referred to the pop-up screening, events that we hold together, where we go into the communities and do PSA blood testing. So we are working with Dr. Bender actually together as part of that process as well, that the men who show prostate cancer would engage the peer navigation program. So we're going to be working together to include them as part of the community pop-ups as well. So there's a lot of work being done around that whole thing.